Are we ready to go? Okay. Hi, everybody. I guess we're ready to go. This is Rich Wolitsky. I'm the Director of the Office of HIV/AIDS and Infectious Disease Policy here at HHS. And I'm pleased to welcome you today to our webinar on reducing homelessness among people living with HIV in order to reach our national goals. Next slide. I think we can probably skip the next one because I've already introduced myself. So let's kind of talk a little bit about what the objectives for today's webinar are. So, this is primarily designed to review the evidence and to get your input about the barriers to stable housing and challenges that community members face in reducing homelessness among people living with HIV. We're going to hear from community leaders and members who successfully worked to address homelessness among people living with HIV, and they'll share their solutions from their communities. We're also going to receive some recommendations from stakeholders who are participating in today's webinar that will be considered by the National HIV/AIDS Strategy Federal Interagency Work Group and relevant federal agencies that have the potential to reduce homelessness among people living with HIV so that we can achieve the goals of the national strategy. Next slide. So today we'll be hearing from a range of presenters across the federal government, and I'll be introducing them in turn as we go into their presentations. But we have presenters from HUD, HRSA, from CDC, and partners from the National AIDS Housing Coalition, AIDS Foundation of Chicago, New Jersey Department of Health, and HRSA HAB as well. So we'll come back to them and you'll hear a little bit about who they are and the work that they've done in just a few moments. But as some context for today's presentation, go to the next slide and just really acknowledge real quickly that housing is an important determinant of health among people living with HIV, and it's also associated with risk for HIV infection. Like many other social determinants of health, such as poverty, unemployment, educational opportunity, hunger and food instability, access to care, racism, and other forms of stigma and discrimination. These interact to put people at risk for HIV and also put people living with HIV at risk for poorer outcomes. So we look specifically on the next slide. These are some old data, now a decade old. Can't believe how fast time flies from when we did this research. But this is data that was published in the American Journal of Public Health from 19 U.S. states and cities that looked at housing status among people living with HIV. This focused on a sample of almost 8,000 people living with HIV, which represented 4% of the overall sample who were homeless. And compared to people who were stably housed, we found that homeless people were less likely to report good or excellent health, less likely to take HIV medication, less likely to adhere to those medications, less likely to have a CD4 count above 200, and they were less likely to have an undetectable viral load. In terms of transmission risk behaviors as well, we found that they were less likely to be sexually active, but among those who were sexually active, they're more likely to have a larger number of sex partners, more likely to have traded sex for money or drugs, more likely to have had unprotected sex with a partner of an unknown HIV status, and they're more likely to misuse alcohol or drugs in the past year and to have had injected drugs. So you see this whole coalition of risk factors that are associated with housing status among people living with HIV. And these results have been shown in a number of other studies as well. When we look at the National HIV/AIDS Strategy and we see how we've been doing, we want to acknowledge that, first of all, in last year's progress report, which was issued in December of 2016, we saw that for 9 out of 14 goals, we had met our targets and things are moving in the right direction. But here you see the red X's represent those 5 indicators where we did not achieve our targets for that year. So if we go to the next slide, we'll really see that, we don't want to see ourselves not meeting targets. And so when we don't meet targets, we have to say, why is this? And how can we do better? The NHOS Federal Interagency Work Group, which is established to monitor and coordinate activities across the federal government, established 3 work groups to address the indicators that did not meet the annual targets, and in fact, all of these moved in the wrong direction. Now, the movement wasn't necessarily statistically significant, but it showed a pattern that we weren't getting closer to our goals, but instead we're moving further away from them. And these 3 groups focused on the issue we'll be talking about today, homelessness among people living with HIV. Another group focused on HIV diagnoses and disparities in these diagnoses in the southern U.S. And thirdly, we had a work group that focused on disparities among gay and bisexual men. In all of these groups, they're asked to review the evidence, take a look at programs that are currently in place and to identify gaps where improvement could be made, and along the way, to get community input into the issue and to share perspectives from the community as part of their recommendations. And so that's what we're here today to do as part of that, is to get some input from the community. So we're pleased that so many of you are here today to talk with us about this issue, which is incredibly important and central to the success of so much that we do. I'd like to, today now begin with introducing our first speaker. It's truly an honor to have our Deputy Assistant Secretary for Special Needs from HUD, Bryon, who's going to talk with us today about some of the issues that HUD is looking at. I mean, she is someone who has worked for many, many years at HUD and has a wealth of experience that's including serving as the Chief Procurement Officer, Senior Advisor to the Acting Deputy Secretary, and as the General Deputy Assistant Secretary in HUD's Office of Public and Indian Housing. And in her new role as Deputy Assistant Secretary for Special Needs, Jemine's work will encompass oversight of not only the housing opportunities for persons with AIDS, or HOPWA, and the Office of HIV/AIDS Housing, but also HUD's homeless program managed by the Office of Special Needs Assistance Programs. So Jemine, take it away. Welcome.
Thank you, Rich. Thank you very much. Good afternoon, everyone. As Rich introduced, I'm Jemine Bryon, and it's an honor to speak to you today. Not only for my work at HUD, but I also had the fortune of having leadership positions at the Housing Authority of Baltimore City and the Philadelphia Housing Authority. From that work at two of the largest housing authorities in the nation, I've seen firsthand that a good home impacts nearly everything around us, and that includes the health and well-being of our families. HUD is committed to supporting Americans living with HIV with safe, decent, affordable housing and the supports necessary to maintain housing stability. As the Deputy Assistant Secretary for Special Needs, as Rich indicated, I oversee the HOPWA program and the SNAPS program. Since 1992, the HOPWA program, managed by the Office of HIV/AIDS Housing, has provided national leadership and resources that support the development and operation of high-quality supportive housing programs. Under HOPWA, HUD makes grants to cities, states, and nonprofit organizations to provide housing assistance and supportive services to low-income persons living with HIV and their families. The fiscal year 2017 HOPWA appropriation was $356 million. Approximately 55,000 households are provided with housing assistance under the HOPWA program annually. An additional 50,000 households are assisted by supportive services that ensure their housing stability. HUD's Special Needs Assistance Programs, SNAPS, received an appropriation of $2.3 billion in fiscal year 2017 for homelessness assistance grants. Through continuums of care, HUD's homeless programs provide funding for efforts by nonprofit providers and state and local governments to quickly rehouse homeless individuals and families while providing services to support their needs. For fiscal year 2017, the continuums of care will serve approximately 11,400 homeless persons with HIV/AIDS. This represents about 4.5% of the total population served in their residential projects. We know the critical role safe, stable housing plays in the ability of persons living with HIV to access and remain in medical care, adhere to HIV treatment, and achieve viral suppression. But we also know that stable housing continues to be an unmet need for many persons living with HIV. Research indicates that between 40 and 70% of all persons living with HIV in the United States experience homelessness or housing instability at some point following their diagnosis. Further, progress on the national HIV/AIDS strategy target of reducing the percentage of persons in HIV medical care who are homeless to 5% or less has not yet been achieved. While the HOPWA program is the only federal program dedicated to the housing needs of low-income individuals living with HIV and their families, the HOPWA program alone does not have the necessary resources to meet the housing needs of all persons living with HIV. Effectively addressing this issue must involve collaboration both across HUD programs but also across federal agencies. And that is why HUD is committed to building on our existing collaborations, as well as finding new ways forward in working to prevent and end homelessness for persons living with HIV. Our current efforts include ongoing collaboration between HUD's Office of HIV/AIDS Housing and Office of Special Needs Assistance Programs to improve the ability of homeless service providers to identify homeless persons living with HIV and link them to housing assistance, medical care, and other services. We want to ensure that the needs of homeless persons living with HIV are considered in the development and implementation of programs for coordinated entry to housing services. We collaborate with the Health Services and Resources Administration's HIV/AIDS Bureau to improve health and housing stability outcomes for persons living with HIV by enhancing the ability of HOPWA providers and Ryan White recipients to integrate data systems in order to share client information and coordinate HIV care and housing services across the two federal programs. HUD coordinates with HRSA and the Department of Labor on an initiative to support the design, implementation, and evaluation of innovative interventions that coordinate HIV care and treatment, housing, and employment services for low-income people living with HIV. And we collaborate with the Department of Justice on a demonstration initiative aimed at improving the housing stability, health outcomes, and safety of low-income persons living with HIV/AIDS who are homeless or in need of housing assistance due to sexual assault, domestic violence, dating violence, or stalking. Those are just some of our current cross-program and cross-agency efforts focused on improving the housing and health outcomes of persons living with HIV. Recognizing that there is much more to be done to make progress on the National HIV/AIDS Strategy Homelessness Target, we would like to hear from you, hear your input and recommendations regarding what HUD and our federal partners can do better or differently in order to achieve our goals. Your input today will be considered by HUD and our partners on the Federal Interagency Work Group as we refocus our efforts on this issue and determine new ways forward in our work to prevent and end homelessness for persons living with HIV. Thank you so much. Thank you to the HUD colleagues, and I look forward to hearing your recommendations later in this webinar. Thank you.
Thank you so much. Thank you for your remarks and also for the tremendous work and service that HUD does for people living with HIV. And I actually, years ago, collaborated with folks on HOPWA projects and really was impressed with their dedication and their commitment to meeting the needs of people living with HIV. So we're really happy to have you here today and to have you as a partner in this work. So next up is a partner who has been somebody I've known for many, many years and I've really enjoyed working with throughout all those years, and that's Heather Hauck. She's the Deputy Associate Administrator of the HIV/AIDS Bureau, or HAB, at HRSA. And as you know, HIV/AIDS Bureau provides leadership and resources to assure access to and retention in high-quality integrated care and treatment services for vulnerable people living with HIV and their families. Technical difficulties going on. Nate has taken them out, and we're good now. So, Heather, really, HAB is the home of the Ryan White program. And we're going to be hearing today a little bit about what we see in those data regarding housing status and its effects on the lives of people living with HIV. So, Heather, welcome, and we're looking forward to hearing what you have to say.
Great, thank you, Rich. And thank you for this opportunity to Great. Hopefully we can do this without echo.
We're trying to look at that.
Heather, there may be, this is Nate. Heather, there may be one or two either lines open in the room you're in, because that's what sometimes happens. There's like an open line as well as someone speaking. So if there's any other people in the room you're with, I think you're in a conference room, if they can mute or turn the audio off on their devices, that should get rid of the echo.
Thank you. I think we may have just accomplished that.
Okay, great.
We love technology. So Rich, thank you very much for that introduction, and thank you everyone on the line for this opportunity for us to talk about the important role that the Ryan White HIV/AIDS program has in improving housing stability among people living with HIV. Next slide. So, next slide. So I hope that many of you on the call today are familiar with the Ryan White HIV/AIDS program, but I am going to run through just a few high-level points about, again, the important role that the program has in the work that we're doing around housing. So for the HIV/AIDS Bureau, our vision and mission are optimal HIV/AIDS care and treatment for all, and we accomplish that vision through our mission of providing leadership and resources to assure access to and retention in high-quality integrated care and treatment services for vulnerable people living with HIV and their families. Next slide. The Ryan White HIV/AIDS program provides a comprehensive system of care that provides primary medical care, medications, and essential support services for people living with HIV. We serve more than half of all of the people living with diagnosed HIV in the United States, over 500,000 people, through our program, and receiving a whole host of services, of which housing is certainly one. Our funding through the Ryan White HIV/AIDS program goes to cities, states, counties, and local community-based organizations. An important component of that funding that goes to these entities is that the recipients at the local level determine their HIV service delivery system and their funding priorities based on local needs assessment with input from people living with HIV. And an important provision of our Ryan White HIV/AIDS program statute is that our program is payer of last resort. In other words, our funds may not be used for services if another state or federal payer is available. This is an important component of our program because it allows us to work with other programs to leverage the finite Ryan White HIV/AIDS program resources to really focus on the needed services that are determined at the local level. Next slide. So, next slide. So in terms of a little bit more about the clients that we serve, these data are from our Ryan White Program Services Report, or RSR, Annual Client Level Data Report. In 2015, we served, again, as I said, over 500,000 people, 533,000 people specifically. Nearly 3/4, or 73%, of our Ryan White clients are from racial or ethnic minority populations. Importantly, our program is a program designed for low-income individuals. So over 2/3 of our clients were living at or below the federal poverty level. And nearly 80% of the clients in the Ryan White program had some form of health coverage during that time period. In addition to this high-level data, we also do a number of other types of analyses through our RSR data that allow us to look specifically at where there are gaps or disparities in health outcomes for people living with HIV. And it also allows us to look at what some of the root causes of some of those health disparities might be. Next slide, please. So when we do that, we have noted over the past 5 years that people living with HIV who have temporary or unstable housing have worse health outcomes. And I'm going to talk about that in a minute. But we always like to talk about why the Ryan White program supports housing. And that is because, and Rich and Jemine certainly pointed this out as well, that we already know from a long history of literature that people living with HIV tend to experience higher rates of unstable housing, and that clients with unstable housing have lower rates of retention in medical care and viral suppression compared to clients with stable or temporary housing. Next slide. So when we look at our data in the RSR report in 2015, you can see that although 85.2% of our clients have stable housing, that still leaves a significant number who have either temporary housing, 9.8%, or unstable housing at 5%. Next slide. So as I said, we use these types of analyses to help us look at what additional initiatives we need to make strategic investments in order to drive improvements in people living with HIV's health outcomes. So on the right hand of this slide, we're taking the data from the previous slide, and what we're looking at is viral suppression among clients across those three housing statuses. So on the right-hand side, the dark green bar are those individuals who have stable housing. The light green are the individuals who have temporary housing, and the yellow are clients who have had unstable housing. As you can see, viral suppression has been improving from 2010 to 2015 across all of those populations, but it's very clear that our clients who have unstable housing have lower overall health outcomes than those who have stable housing, and are certainly significantly lower than our national average across all people in our program, which is 83.4% viral suppression. So as we look at these data and think through what is it that we could be doing to, again, drive improvements, we focused on a couple of special initiatives, two of which are on the left. Jemine already talked about these. These are very important collaborations for us, both with HUD as well as the Department of Labor on the top one, which focuses on supportive employment, housing services, and healthcare services. And certainly our ongoing work, as she mentioned, around data integration, the one on the bottom left, is with HUD. One that is not on this slide, but we wanted to make sure to also mention, is we here at the HIV/AIDS Bureau have had a special projects of national significance project, which is titled Building a Medical Home for Multiply Diagnosed HIV-Positive Homeless Populations Initiative. It's currently in its fourth year of implementation, and this has been looking at innovative practices to increase entry to and retention in HIV care, as well as support services for clients who are homeless or unstably housed, and in addition may be living with mental health issues or substance abuse disorders. So we're very proud of the work that we're doing in all of these areas, and look forward to being able to disseminate the outcomes from these various projects. Next slide. In addition to the special projects that we've invested in over the past couple of years, we also do the majority of our housing-related work in the core work of the Ryan White Parts A, B, C, and D. And we try to really, even though many of those recipients may not directly fund housing services, the majority of our Parts A, B, C, and D coordinate services in some way with other existing housing services. As I mentioned earlier, we maximize and leverage other systems in order to provide this housing support. So on this slide, we just listed a few examples of the ways in which support for housing is coordinated. We know that in order to achieve our national goals related to HIV and homelessness, we really need innovative approaches designed to coordinate HIV care and housing services. That means that we need to continue the collaborations that we've begun, as well as working at the local and state level to continue collaboration at those levels. And we are very much looking forward to today's webinar to hear how our community partners are leveraging across our systems, as well as hearing the dialogue that today may inform our future ideas for how to work to address housing instability for people living with HIV. And with that, Rich, I will turn it over to you.
Great, Heather. Thanks so much. Really appreciate you packing in so much information into such a concise presentation. I guess we're going to move on right away to our next presenter, and we're going to hear from Amy Palilonis, who is a Senior Program Specialist in the Office of HIV/AIDS Housing in HUD, and she's actually one of the co-chairs for the subgroup that has been looking at the issue of housing status among people living with HIV for the NHOS-FIW. She started her federal career as a Presidential Management Fellow, and she's been with the Office of HIV/AIDS Housing since 2009. She holds a Master's of Social Work degree from Columbia University, and really just has been a great colleague to work with and has been a real leader on this issue. So Amy, I'm going to turn it over to you to share your information with the group. Amy, you can go ahead.
Rich said,
Great.
Oh, can you hear me?
Now we can. Thank you.
Okay, great. Okay, great. Well, thank you, Rich, and hello, everyone. I'm going to tell you a little bit about the subgroup of the National HIV/AIDS Strategy Federal Interagency Work Group that was formed to identify opportunities and ways to effect change to reduce homelessness among persons living with HIV. Next slide. Oh, actually this slide. As Rich had mentioned earlier, the 2016 National HIV/AIDS Strategy Progress Report provided an update on the indicators being used to measure progress to achieving our nation's HIV prevention, care, and treatment goals. While the report showed progress on many indicators, it showed that progress is not being made on Indicator 7, which is to reduce the percentage of persons in HIV medical care who are homeless to no more than 5%. The report indicated that of persons in HIV medical care, 9% were homeless in 2014. This result did not meet the annual target of 7% and showed an increase from the 2010 baseline. I'm not going to go into any more detail regarding Indicator 7 right now because Jennifer Fagan from the CDC is going to provide more information on the indicator and the data behind it in a few minutes. So in order to determine why progress is not being made on the indicator and what changes to programs, policies, and services could better move the indicator in the right direction, the National HIV/AIDS Strategy Federal Interagency Work Group established a homelessness subgroup to delve into this issue further. Next slide, please. So the subgroup is made up of subject matter representatives from various federal agencies that have a role in addressing homelessness for persons living with HIV. As you can see on the slide, many federal agencies and offices are represented on the group, including the Department of Housing and Urban Development, the Department of Education, Centers for Medicare and Medicaid Services, the Substance Abuse and Mental Health Services Administration, the Centers for Disease Control and Prevention, the Health Resources and Services Administration, the Department of Labor, the Administration for Children and Families, and the Department of Veterans Affairs. The subgroup is co-chaired by Harold Phillips from HRSA's HIV/AIDS Bureau, who's also on this webinar today, and then I am the other co-chair of the group. Next slide, please. So the subgroup is undertaking several tasks to help identify reasons why the indicator reflects a lack of progress, as well as opportunities to effect change and new ways forward that can move the indicator in the right direction. These tasks include a review of the indicator data. We're lucky enough to have Jennifer Fagan from the CDC as a member of the subgroup, and she has provided an in-depth overview of the indicator and the data behind it to the subgroup members and has been a great resource for any questions about the data that we've had. We've also identified data sets and other resources from across the subgroup member agencies that can help provide more information on the issue of homelessness for people living with HIV and give us some insight on why progress is not being made on the indicator. We are conducting a review of the existing National HIV/AIDS Strategy federal action items related to homelessness, as well as determining what else is being done across the federal government on the issue that may not be included in the strategy, but that could be scaled up or built upon and promoted as an opportunity to effect change. We're also working on a logic model that identifies the inputs and activities necessary to create short and long-term changes that could improve progress on the indicator. The logic model will be, included in our subgroup report that will be published early next year, and the report will detail the tasks that the subgroup has undertaken over the last year, as well as our recommendations on what new initiative or changes to existing programs, policies, and services could better move the indicator in the right direction. One critical component as our work as a subgroup is community input. The work group has been encouraged to reach out and engage with the community to obtain input on what others across the country have found to be successful strategies for addressing homelessness for persons living with HIV. And as Rich said, that's why we're having this webinar today. To hear from all of you, both the expert panelists that we have on this webinar, as well as the community members and stakeholders that are listening in on this webinar, to gain input into our work as a subgroup and the recommendations that we'll be putting forward. We want to hear what's working in your community, what isn't, and what opportunities you think exist for the federal government to effectively make progress in preventing and ending homelessness for persons living with HIV. So we're really looking forward to hearing from everyone on the webinar today, and I definitely encourage you to speak up and share your insight on this issue during the listening session component of today's call. Thank you.
Great, Amy. Thanks so much. I'm really pleased to have you here today. So I promise this is going to be the last of our federal presentations in this warm-up to community input. But I'm really pleased to introduce somebody that I worked with just a little bit while I was at CDC, Jennifer Fagan. She's a health scientist in the Behavioral and Clinical Surveillance Branch in CDC's Division of HIV/AIDS Prevention, where for the past 10 years, she's served as the interview lead for the Medical Monitoring Project, or MMP, which is a national surveillance system among adults living with HIV in the U.S. Jennifer has a passion for understanding sociocultural influences on infectious diseases, which stems from her previous work in the U.S. and overseas in her training as a medical anthropologist. And so we love people with passion, Jennifer, and we're glad to have you here today. So I guess why don't you go ahead and kick us off with your first slide from the MMP project.
Great. Thank you so much, Rich. So good afternoon, everybody. The Medical Monitoring Project, also called MMP, is the data source for the National Indicator on Homelessness among people living with HIV. And we've been using data for MMP since 2010 to monitor our national goal to reduce homelessness among people living with HIV to 5% or less. Next slide. So in the next 10 or so minutes, I'm going to briefly describe the MMP project, the survey questions that we use to measure homelessness. Then I'm going to report some findings on homelessness using MMP data, and then end with some discussion points. Next slide. MMP is an HIV surveillance system, and it uses a cross-sectional design, which means it captures information at a specific time period. MMP produces annual population-based prevalence estimates, and the data is really unique in that it's both nationally and locally representative. MMP covers a broad range of topics related to behavioral and clinical characteristics among people living with HIV. And from 2009 to 2014, MMP data collection cycles, we have weighted data among adults living with HIV who were receiving medical care. And then for the 2015 data collection cycle and onwards, we now include all persons living with HIV, regardless of their care status. So starting in 2015, MMP uses a two-stage sampling design. And so during the first stage, we sampled 16 states and 1 territory from 50 US states, Washington, D.C., and Puerto Rico. And during the second stage, we sampled HIV-diagnosed adults reported to the National HIV Surveillance System. Before 2015, we had a 3-stage sampling design, and that also included sampling from HIV care facilities. Next slide. So for those of you who can see the slides, this is a map of the participating states and separately funded local health jurisdictions who participate in MMP. And all areas with high HIV prevalence in the US are represented, as well as some areas with medium and low HIV prevalence. Next slide. CDC state and local health departments jointly run MMP through a cooperative agreement. MMP includes a personal interview and a corresponding medical record abstraction. About 4,000 people living with HIV in the US participate each year. We collect data starting in June and ending in May every year. And we measure homelessness through the personal interview. So trained interviewers administer the survey questions using a computer-assisted personal interview. And the interview takes about 45 minutes to administer, and it's either done face-to-face or over the telephone. The MMP interview instrument covers a wide range of topics, and in fact, there are 23 different modules that are covered during the MMP interview. Next slide. So here's a link to the MMP website. You can find more details here about sampling, weighting, publications. Also, our data collection instruments are there if you're interested in seeing the interview and what's collected in the medical record abstraction. You can go there. And the link, you can also go to the CDC website, and if you search for MMP, you'll find it there. Next slide. So this is about the measure that we use for homelessness. So we've used the same question to measure homelessness since 2009. And we did this to ensure systematic and consistent data collection so that we can monitor trends over time. We don't use the term homeless in the interview question, as some individuals who fall under the broad definition of homeless may not consider themselves homeless. And the measures derived from the McKinney definition of homelessness. Next slide. So we asked respondents, during the past 12 months, have you done any of the following? Lived on the street, lived in a shelter, lived in a single room occupancy hotel or SRO, and lived in a car. If any of these questions are endorsed by a respondent, then we categorize them as homeless. And then, as with any questions in MMP, respondents can always answer, can always refuse to answer a question, or they can reply that they don't know the answer. Next slide. So also, in addition to the homeless questions, we have received some comments from stakeholders in the community in the past that we should include questions to measure housing stability. It's important that our homeless measure remains exactly the same so that we can monitor trends over time. But however, in addition to the homeless questions, we will be asking MMP respondents questions to measure housing stability. So we'll add the new housing stability questions to the questionnaire starting in June 2018, so this upcoming summer. And the data will be available probably around sometime in summer of 2020. We'll ask about the number of times the respondent moved, whether he or she doubled up due to financial problems, and whether he or she was evicted during the past 12 months. Next slide. So this slide shows the percentage of MMP patients who reported homelessness in the data collection cycles from 2010 to 2014. And if you look at the column with the percentage or point estimates, you might think that the numbers increased over time. But if you look at the column with the confidence intervals, you can see that the range of estimated percentages is actually overlapping across the years. And this tells us that the numbers have actually remained stable across years. Next slide. So we also ran a trend analysis to determine whether there were significant differences across the years. And the beta represents the average percentage point change each year, and the p-value tells us whether the trend is significant. And here we can see that the change across years is not significant. We can also, if you're looking at the line, you can see that it's relatively straight across years, which tells us if there's not been a significant change. Now, optimally, we would like to see the line moving downwards so that we can reach our goal to decrease homeless to 5% or less. Next slide. So the next two slides provide characteristics of persons reporting homelessness in MMP, combining data from 2009 to 2012. And of those who reported homelessness, the majority were male, 71%, Black, non-Hispanic, 53%, 72% were at or below the poverty level using HHS guidelines, and 20% were incarcerated for more than 24 hours during the 12 months preceding the interview. Next slide. Over a third of respondents had expressed having symptoms of depression based on the PHQ-8 depression scale. 23% were either uninsured or only had Bryon White program coverage, and the majority were diagnosed for 10 years or more, and only 60% were virally suppressed. Next slide. The MMP interview data are subject to standard survey errors such as interviewer error and social desirability bias. The percentage of homelessness among patients living with HIV remained the same from 2010 to 2014. And it's unclear whether sampling modifications that we've made in 2015 and for the 2015 data collection cycle will affect homeless estimates. However, preliminarily, we've looked at unweighted analysis, and they appear to be similar to previous years. And the results of weighting and analysis will be available in late November this year, meaning in a couple of months from now. Next slide. So feel free to reach out to me with any questions or comments. Again, it's Jennifer Fagan, and my email is jfagan, F-A-G-A-N, @cdc.gov. So thank you very much.
Great, thanks, Jennifer. So this is Rich, and I'm sure we're going to have some questions about the analysis of the trend data over time. I know I've got one for you. But before we go to that, I'm going to go ahead and hear from Christine Campbell, who is somebody who I haven't seen for years, who has really been in this field for quite a long time and is well known to, I think, pretty much everybody who works in the arena of HIV and housing. She works with the National AIDS Housing Coalition, where she spearheads their Housing as Healthcare initiative and provides technical assistance to HOPL grantees and allied communities in developing HIV housing care continuums. Ms. Campbell also works with Collaborative Solutions, providing technical assistance to HOPL grantees on HOPL formula modifications and modernization and implementing the new formula. Ms. Campbell has a master's degree in Science and Organizational Development from American University and is really a committed advocate in this arena. So Christine, I won't get to see you, but it's good to hear your voice again. Welcome.
Thanks, Rich. It's great to hear your voice again, too. I'm so glad to be part of this group. The National AIDS Housing Coalition has been honored to be able to partner with several of these agencies and community-based organizations to really promote HIV/AIDS housing, and now our real focus on how we can use housing and other structural interventions to really end the epidemic. Next slide, please. So our vision at the National AIDS Housing Coalition is that we envision an international community where housing is a human right and HIV disease ends. We know that it's clear that housing improves health outcomes of those living with HIV disease and reduces the number of new HIV infections. The end of HIV/AIDS critically depends on the end of poverty, stigma, housing instability, and homelessness. Next slide. So over the years, we've been really looking at housing's role and how it plays a role in addressing the treatment cascade. And we have found that several things are true, that people living with HIV and AIDS who are homeless or unstably housed are fall lower on the treatment, the HIV care continuum than most people. They're less likely to delay their entry into care. They're less likely to be connected to care. They're less likely to be retained in care. They're less likely to be on treatment. And they're less likely to obtain what we're all hoping everyone achieves, which is viral suppression. So over the years, we've been looking at ways that we could really look at the impact of housing on the HIV care continuum. And we partnered with New York City several years ago, next slide, to really look at their HIV care continuum and overlay their HOPL services on top of it. Several years ago, John Rojas came, before he was even a board member, came to the National AIDS Housing Coalition board meeting and showed us what they were able to do when they overlaid their HOPL services over the care continuum. And as you can see from this slide, the bars in 10, the tan bars are their HIV care continuum. And the red bars are what happens when you overlay HOPL services on top of the care continuum. Those people who are receiving some form of HOPL services, you can see, are more likely to enter care, be retained in care, be adherent to treatment, and ultimately be virally suppressed. We then had the opportunity to partner with the Office of HIV/AIDS Housing and Collaborative Solutions to work with communities around the country to develop these care continuums so that people could take a look at the impact of housing on improving health outcomes and really moving towards viral suppression. And we didn't just want this as a piece of information that people could have, but we really wanted them to use this as a tool in planning. How do we make, in this diagram, these tan bars higher? How do we make them more red, as you could be using to use this diagram? What needs to happen to actually increase those opportunities? And one of the things, for instance, New York is looking at is why aren't they increasing? What is that difference that makes that tan bar shorter than the red bar? So we wanted these to be used as tools to really move communities and look at the interventions that were really instrumental in making a movement and improving health outcomes. So in some of our work doing this, we started a housing and health initiative where we really looked at housing as a structural intervention. We really looked at how housing really has and I can now say this, has a causal effect on improving health outcomes. So how do we use this in program design, in resource allocation, and really improve what's been happening around the homelessness indicator? When the update came out, you can imagine the people in the housing community were distressed that that was one of the key areas that did not see any real improvement. And one of the things that we have been really advocating for is housing, as well as other structural interventions, are going to be needed to be integrated into all strategies to end the epidemic for the treatment to be effective. Next slide, please. So we started looking at what are our opportunities to make progress on this homeless indicator. Next slide. So as part of our housing and health initiative, we really started looking at how can we connect funding for health care and housing. We have some docs who work with us who are saying, you know, what we should be at the point of is giving prescriptions for supportive housing. That's how much they believe that housing is a medical intervention to improve health outcomes. And we know that that's a little far-fetched, but we do believe there are opportunities where we can really more closely connect funding for health care and housing. A couple of years ago, HRSA put out a memo that really encouraged communities and showed communities how they were able to use Medicaid better in housing settings for supportive services. And you know, we're very much supportive of that, and we want to see that, because if we're able to connect those services better, we will be seeing improved health outcomes. We also know that there's some communities, and you may hear a little bit about this when Peter talks about what's going on in Chicago, how some communities are really looking at outcomes and how when you house people, there are huge savings in medical treatment, and some communities are being incentivized by that. Is there a way that these communities can partner to use that to be able to develop housing to ensure improved health outcomes? Another thing we've been really looking at is the inclusion of unstably housed in the homeless definitions, or at least in terms of eligibility for services. So we're really encouraged to hear that there's going to be new opportunities for data collection to really look at unstably housed. We've been doing some work with the communities of care and trying to say, how can we really work better together, given that we don't necessarily speak the same language as the communities of care. So how do we look at the coordinated entry system in such a way that we're able to at least work with some of our people living with HIV, and how we can make sure that people are getting into the services that they need as quickly as possible. And then the other thing we've been really looking at is how housing can be a cost savings, cost-effective prevention and treatment intervention? How do we actually include this in the milieu of services that we are providing with and for people living with HIV, and kind of understanding that it's broader than just HIV, and that many of the people that we work with, HIV is not their only concern. They're dealing with other things in their life, and how do we look at this from a very holistic perspective? Next slide. So we also understand there's some real advocacy opportunities here, and with the National AIDS Housing Coalition being an advocacy organization, we have the opportunity to hear the data, to hear the research, and then use that information to really make policy change. So of course right now we've got the federal advocacy, and we're looking at the appropriations, and if anyone's, as you probably are all aware, we're in the middle of a fight for our life right now with the health care bill that's going on. So we're doing a lot of work around making sure that we've got the best health care system possible, given the current situation. So we need it to be affordable, we need it to be accessible to all people with chronic conditions, including people living with HIV and AIDS. We've got the appropriations work that we're doing to make sure, one, that the HAPA funding gets increased to be able to really solidly implement the new formula, the HAPA modernization formula that we really want to make sure gets implemented effectively and efficiently. And the only way that can happen is if there's appropriate funding for that. But the other thing that we also know is that HAPA does not operate in a vacuum. So we strongly advocate for funding and services and comprehensive services throughout the entire HUD portfolio. Because if you pull away any piece of the other parts of the HUD portfolio, then HAPA will fall. So you cannot just have a strong HAPA program without having a strong HUD. So we're really strongly supportive of that. And the other thing is that we also know that there are regional opportunities. In that right now several communities are really focusing on plans to end the epidemic. How are they going to really work to get to decreased number of new infections, decreased increased number of people on treatment, and an increased number of people with viral suppression. And one of the things that we know is that there has to be an inclusion of housing and other structural interventions in these plans to end the epidemic. And when I'm talking about other structural interventions, I'm talking about things like employment, food and nutrition, legal services, making sure people's rights are protected. And the other thing too is we know that especially at the regional and local level, this is not going to be a governmental solution. We need to really promote innovative public and private partnerships that can be sustainable over time. So those are some of the things that we're really working on to really make sure that we are able to solidly address the homelessness indicator of the National HIV/AIDS strategy. But we also understand that it's not just that indicator that we have to work on, but it's all of the elements of the plan to really make a strong effort to really end the epidemic. Next slide. And here's my contact information. You can reach me at ccampbell@nationalaidshousing.org, and you can go to the National AIDS Housing website for more information. We will be hosting another research summit because we see the connection between research and policy and advocacy to be closely entwined. So we will be having another research summit next year. All that information is on the National AIDS Housing Coalition website. And thank you so much for this opportunity.
Great, Christine, thank you so much. And I will say to folks who haven't been to the research summit before that it's really a great meeting. I've been to several of them in the past and found them incredibly informative and useful. So our next speaker is going to be from the AIDS Foundation of Chicago, which has really been kind of a leading force in the issue of housing for people living with HIV and housing as healthcare. And we're going to hear from Peter Tepfer, who serves as the Vice President of Housing for the AIDS Foundation of Chicago. He's been working with people who are homeless as part of his career for the past 13 years in both direct service and leadership roles, primarily in the supportive housing realm. AIDS Foundation of Chicago's housing team advances innovative, models to address the needs of people living with HIV who are experiencing homelessness, and he currently leads several large community collaborations at AFC to address systematic barriers to housing and health for people living with HIV. So even though I jumbled that a little bit, Peter, welcome, and we're looking forward to hearing what you have to say today. Go to your first slide.
Thank you very much, Rich. I appreciate the introduction, and it is a privilege to be on this webinar with all my esteemed colleagues. I've been taking a lot of notes, and I look forward to taking even more diligent notes when we hear from other community members around the country. Next slide, please. So what I'd like to talk about today is the role that AFC has in our community, some of the local challenges that we see, and then, of course, how we are addressing some of those challenges through innovative approaches. And finally, what we see as some future opportunities given the landscape and potential funding. Next slide, please. The vision of the AIDS Foundation of Chicago is that people living with HIV and related chronic diseases will thrive, and that new HIV infections will be rare. And our mission is to mobilize communities to create equity and justice for people living with HIV, living with and vulnerable to HIV and related chronic diseases. Next slide. So AFC plays several roles in our community. One of the largest is leading programs, including housing and being the grantee from the local health departments around the Ryan White programs. So with our housing portfolio, last year we served over 1,000 people in our long-term housing assistance programs, including supportive housing. 283 people received rental and utility assistance, and we also provided all of these services through our network of partner agencies. So that bottom left-hand slide highlights that AFC relies very heavily on community partners to do the direct service, including the Ryan White case management, supportive housing case management, and other needs. One other thing that's important is that we also have a robust policy department and interface with the National AIDS Housing Coalition on national and state initiatives. Next slide, please. The Housing First philosophy is at the foundation of our work. For folks who are not as familiar with Housing First, it means that people have access to immediate housing and services, not that they have to jump through hoops or qualify based on certain behaviors. We believe that a home is the best place to address any challenges that people have, and there are minimal requirements. So there's not a requirement for sobriety, adherence to medication, whether it be medical or psychiatric, and that no other types of treatment are mandated. People pay 1/3 of their income towards rent, so that's an affordable level, and if people don't have income, they don't pay any rent whatsoever until they gain that income. And finally, we value autonomy and self-determination. So residents in our program hold their own leases. They have all the protections and responsibilities of being a leaseholder. And what we found as part of our participation in the Chicago Housing for Health study, which is published in the Journal of the American Medical Association, was that this Housing First philosophy and the case management services that come with it do in fact promote housing stability and cost savings for residents who are highly vulnerable and coming from the hospital. An important part of this philosophy for AFC is that we use both harm reduction and motivational interviewing techniques to support this work so that people have an array of services available to them and opportunities to make the changes that they see are most important. Next slide, please. So AFC is, we like to talk about ourselves as air traffic controllers. We have our hands in a lot of different activities, but they're all intertwined. So we keep our eye on the overall vision of impacting people's lives and changing the systems with which they interact. That means that we look at the individual programs as well as the systems that are part of people's lives, because we believe that if we can help systems be more accessible and more person-centered, that people are going to be more successful. Next slide, please. Part of this systems level view and the air traffic controlling is also looking at the challenges that we have. One of the first challenges in Chicago is that we do not have a full understanding of the scope of homelessness among people living with HIV and AIDS. We are part of the project that is influencing the National HIV Indicator. However, when we look at different indicators here locally, you can see on the right-hand side that our local point-in-time count showed that there was 179 people who were living in the streets or the shelters who were HIV positive. We know that that is likely underreported. People are not often eager to disclose their status to volunteers at a certain point in time. And we also know that with our Ryan White statistics, as Heather mentioned, that about 15% of people in their care plans indicated temporary or unstable housing. And so in Chicago, that means that over 500 people indicated that they had a housing instability barrier in their care plans. So we're taking efforts to find a more precise number so that we know exactly what we're dealing with. Next, we have a, oh, can you go back one slide, please? With the viral suppression, as Christine mentioned, we also were able to create a local treatment cascade for a portion of for a portion of HOPO recipients, which was a great first step. So Christine, we were early adopters of trying to do that, and we realized that there were some gaps, that it didn't encompass everyone who was receiving HOPWA. It also was historical surveillance data from our health department and not necessarily real-time information that could help us in the present to change our interventions. And finally, Chicago sees a lack of coordination. So people will access housing in whatever ways that they can get it. And sometimes what we see is that without a clear pathway, people will access housing that doesn't necessarily match the service level with their service need. So people might end up in a program that has very little services when they could be more successful in a program that has a higher level of services. Next slide, please. So what are we doing to address these challenges? The first is that we see community collaboration as absolutely essential to making these changes. Chicago and Cook County are big, and we need input from a variety of different people to make this, make the types of changes that we need. Second, we need to align our housing with the Ryan White funding that's available. AFC is an advantage because we coordinate all the Ryan White funding and a large portion of the HOPWA funding in Chicago. Finally, the data integration efforts are absolutely essential, both as we look at scope and incidence as well as viral suppression. And finally, we need to be creative in the way that we braid funding so that we can stretch each scarce dollar as far as possible. Next slide, please. So we have a number of examples of strong community collaborations here in Chicago. One is the HIV Housing Constituency Group, which is made up of providers, advocates, and public officials that are looking to improve the HIV system of housing here in Chicago. We've recently identified several priorities, some of which are also part of the innovations that we are in the process of undertaking. And some of those priorities that the group has are a connection to other systems. So specifically employment, healthcare, the coordinated entry system. We also are looking to make sure that people are matched to the right housing type and service level, integrating data, ensuring that there are housing options for people who are not yet HIV positive but at high risk for being infected. And finally, making sure that we expand our housing connections to other mainstream resources, because HOPWA is not going to be the only source in order to address this need. Next, we have a pretty strong partnership with our local health departments. So both the Chicago Department of Public Health and the Illinois Department of Public Health have been very strong partners in helping us to achieve some of the goals that we've identified. Some of the data integration work is also a priority of those health departments and are helping us to unravel and untangle some of the knotty issues that come with linking data systems and finding bridges between data elements. Chicago was one of the adopters of the H2, or Housing for Health Strategic Plan, that HHS and HUD encouraged a few years ago. And in Chicago, we identified several priorities for that plan that is across Cook County, which in and of itself is a success, because often the city of Chicago and the larger county have not coordinated particularly well. And this effort brings together hospitals, public officials, managed care organizations, service providers, and other systems level folks to look at how we bring the housing and health sectors together so that it's in fact one web of services surrounding someone instead of siloed housing and healthcare services. And finally, we have a strong presence and connection with the local continuum of care here in Chicago, and are exploring ways to make sure that the coordinated entry system for everyone experiencing homelessness is also responsive to the needs of people living with HIV. Next slide, please. We've been looking at people who are duly enrolled in HAPWA and Ryan White programs as a way to find out if people have achieved viral suppression. As I mentioned earlier, our surveillance data was a good start, but incomplete. And so this is one of our efforts to look at people who are also in Ryan White medical case management to see what their viral suppression numbers look like. And as a result, we've found that there is, for people specifically in programs that are not supportive housing, that we have pretty strong outcomes in that area. We are also looking at having housing navigation embedded at primary care clinics in our communities. So the places where people are already going for services and for care could be places where we have staff who can help them to access housing, both HAPWA, other rent subsidies, or affordable housing in our community. So making sure that there is that tight connection between the healthcare locations and our housing system is really important. That is a main front door for people living with HIV. And finally, we have an assessment that looks to match people with the correct service level. And it's one that we can use to, that we can adapt as we're seeing if in fact people are matched to the right service level. Next slide, please. With our data integration, we've had a couple very successful projects. One I already mentioned, which was looking at our HAPWA recipients who then were cross-matched with the local surveillance data, where we had a similar treatment cascade to the one that Christine showed us from New York. Another is that our HMIS project is also working with the local health department surveillance department to see who to see the people that are enrolled in HMIS who also are HIV positive. This will be one of the first times that we will have a concrete number of people, both those that are enrolled in COC programs and those that are homeless, still on the streets of the shelters. It is unfortunately a de-identified match based on some of the consent issues that we've run into, but it's a very important first step to help us understand that scope. Finally, HMIS will also be doing a data match with the Capricorn database. The Capricorn database is a research tool that's used by 11 of the academic research hospitals here in Chicago, and will look at the movement of people between hospitals, as well as their different diagnoses. So again, looking at these data systems, finding ways for them to talk to each other and give us some of that important data that can inform our policy and our different programs. Next slide, please. Finally, we braid funding so that we can move our, make our dollars go farther. So we have the HAPA money that is often used for, that we also leverage against local subsidy sources, as well as HUD COC money. So we actually create HIV dedicated housing by matching against other subsidy sources. We can also bring service money from other sources to match against the tenant-based rental assistance of HAPWA. And finally, making sure that we are addressing some of those behavioral health concerns. At AFC, we have an in-home behavioral health program to serve people who are HIV positive. Next slide, please. So some of the future opportunities is that with the HAPWA formula change, Chicago is planning to see an increase, and we are currently giving input into what we see as the priorities for how that funding could be used based on our local need. We know that that's not necessarily the case everywhere in the country, but we know that it's going to be very important to use that money in the most efficient way possible. We're also looking at creating population-centered health homes, which includes prevention, care, and housing as ways to integrate all those different aspects of HIV care into a single source, potentially geographic, potentially based on the various needs of our communities. Chicago is also the recipient of the HRSA opportunity that combines employment, housing, and care that Jemine Bryon referenced earlier. And finally, we are adopting a Getting to Zero framework to look at ending new infections across the state. So there's a lot happening here, but also a lot of room to learn from what's happening in other parts of the country. So with that, I will finish, and thank you again for this opportunity.
Great. Thanks so much, Peter. Really appreciate the presentation. I mean, there are a number of things that you mentioned that made me feel really happy to hear them, and I know that, you know, Secretary Price would also probably be happy to have heard a number of the things you mentioned that were consistent with his desire to see greater integration of services in a way that's centered around the patient and not so much driven by the funding stream, and very much in favor of busting silos and braiding and integrating funding sources to provide services that really meet the need of the whole person. So I think it's really great work that you all are doing. So we kind of heard from a community perspective, from a community-based organization. Now we're going to hear a different community perspective from the health department perspective. And so we're going to hear from Loretta Dutton. She's the Director of HIV Care and Support for the New Jersey Department of Health. And for the past 2 years, Loretta has been focused in the HIV Care Unit on building infrastructure, collaborations, sound data collection approaches, and accountability to serve as a foundation for innovative approaches for doing the work that they do and making people's lives better. Loretta, welcome, and we're looking forward to hear what you have to say about your work in New Jersey.
Thank you, and good afternoon, everyone. The New Jersey Department of Health embarked on this housing initiative to address disparities in HIV identified through our surveillance and HIV care continuum data. In 2015, we found that African American young gay men were the only population not experiencing a reduction in new infections, while all other populations were showing significant downward trends. 72% of new infections among all gay men were among minorities, especially ages 13 to 24. Evidence also showed that the group to have experienced homelessness, abandonment, stigma, mental health disorders, substance use disorders, a history of sexual abuse, and post-traumatic stress that too many times resulted in suboptimal care. The intersectionality of these variables could not be ignored if the goal was long-term behavior change. The vision of the division was a supportive environment, one that we would actually live in, that actually meets the clients where they are. The home would address the complex needs of sexual abuse, abandonment, mood and anxiety disorder, adjustment disorders to include psychotic disorders if the client is compliant with medication, and generational addiction and poverty as precursors to high-risk sexual and drug use behaviors that led to chronic homelessness. These factors, coupled with the emotional and psychological impact of HIV diagnosis and living with HIV, we felt called for more intensive care and one that removed the daily stressors of living on the street. Because of these multiple barriers, our clients are least likely to engage or be retained in HIV care. Next slide. We started talking about seeking substantive funding initiatives by first looking at what we were funding now. Those of us with drug treatment experience continuously hear the words warehousing clients rather than dealing with issues that preceded risky behaviors. Using an old definition of insanity, we in HIV care were expecting a different result with the same menu of services. We knew our offering would have to be sustained, aggressive, with a clinical approach. So homelessness and the lack of access to basic needs is a significant driver. It impedes the goals set forth in the National HIV/AIDS Strategy. Evidence has shown that there is a direct connection between housing and improved outcomes. As people on this call have said, stable housing produces tremendous outcomes along every step of the continuum. Although we acknowledge the need for housing, we believe traditional housing programs, scattered housing and emergency placement, cannot adequately address the multiple and complicated needs. Recognizing this, DOH attempted to address the disparities of HIV among young gay men as a function of ethnicity, sexuality, and socioeconomic status, which highlighted the need for a comprehensive housing program that is culturally responsive. This has resulted in a highly structured program that combines the best of two worlds, a safe, nurturing home environment coupled with clinically based interventions treating the whole person, to some extent resembling a medical home model of care. Next slide, please. With national focus on housing, it seemed logical that housing would be imperative to viral suppression. But what type of housing? After reviewing the integrated plan and discussions with our Part A, we focused on the three top areas identified by the needs assessment: housing intersecting with mental health and behavioral health. Learned helplessness and generational hopelessness keeps clients repeating the same behaviors, thinking there are no other options. The home we envisioned builds hope for a meaningful and productive life. As stated, we developed a structured, clinically based intervention provided by licensed professionals in a non-judgmental, nurturing environment. Sustained interventions using the HUD definition of transitional housing, our program duration is up to 2 years with an aftercare component to increase the likelihood of long-term change, creating a healthier routine that becomes the norm. The culture of the home would capitalize on the interaction of the new family dynamic, including communal meals. The staff, too, would have a phase system, which includes a 90-day orientation period, which they complete their trainings and acclimate to the house culture. However, not everyone hired was a good fit, and every effort is made to select the right candidate as a permanent employee. Discharge planning was to begin at admission. While dural viral suppression is the ultimate goal, the young person learns that he has a hope for a future. Next slide, please. The critical elements of our program is housing and life skills, basic needs and life skill coaching. We have an RN-led medical case management component, directly observed medication therapy, mental and behavioral therapy, including trauma-informed care, psychosocial support, and dialectic behavioral therapy, DBT, was one of the non-negotiable elements of care to participate in the DBT program. DBT is a form of cognitive behavioral therapy that helps the individual change behavior patterns that could be considered harmful, like substance use and self-harm, by making individuals aware of their triggers and applying coping skills. It has proven quite effective for the people with post-traumatic stress as well. Behavioral contracts to fully participate in the program were contingent and a contingency for admission. The phase system is used to earn past privileges. The program works on a phase system. Each phase prepares the resident for independent living and gets him a little closer to that ultimate goal. He is assessed at each step of the way for readiness, and as he moves through the phases, he gains more independent living skills and increases treatment adherence. Throughout each phase, the resident gains more freedom and more responsibility. In terms of mentoring, the staff at the house recognize the incredible leadership potential the residents have and created a peer mentorship program to cultivate and utilize those skills. We also include the co-location of prevention and education programs. We are really trying to meet the client where they are. Many programs like to say they meet the clients where they are, and sometimes they really mean they want to meet them where you want them to be. An overly compliant client does not mean they are fine. Critical to our approach is to understand where the client is, what issues he's addressing, like post-traumatic stress, that may impact current behavior, and use that behavior as a treatment moment and not as a dischargeable offense, as long as there's no threat to himself or others. Next slide, please. Models of care selected were DPT and motivational interviewing. DPT is support-oriented. It helps the client identify their strengths and builds on them so that the person can feel better about his life. DPT helps identify thoughts, beliefs, and assumptions that make life harder, like I have to be perfect at everything, or if I get angry, I'm a terrible person. It helps people learn different ways of thinking that make life more bearable, such as I don't need to be perfect at things for people to care about me, and everyone gets angry, it's a normal emotion. DPT requires constant attention to relationships between clients and staff. In DPT, people are encouraged to work out problems in their relationships with their therapist, and the therapist to do the same with them. Critical to the approach is that both between and during sessions, group and individual, the therapist actively teaches and forces adaptive behavior, especially as they occur within the therapeutic relationship. The emphasis is on teaching patients how to manage emotional trauma rather than reducing or taking them out of crisis. Access to clients in a housing program rather than appointment or telephone interviews, and the interaction between the clients themselves has proven to be an enormous asset to growth and leading to self-management and independent living. Next slide, please. The process the state took is to develop an RFA that provided clear intent on structure criteria for licensed, credentialed staffing and advanced degrees for direct service staff, screening processes and observed orientation for support staff, and the orientation would focus on a cultural fit, identifying biases and weaknesses that would prohibit the accepting, nurturing environment desired. Applicants must show evidence of broad housing expertise, not just the dispensing of housing vouchers or arranging for emergency stays. The applicant must show a keen awareness of the critical interventions and understanding of the need to address in parallel the clinical needs individually mapped for each client. Structure and contingency management as tools for effective stability were to be used. Next slide, please. Utilization measures included bed days, units of medical case management, mental health counseling, DBT therapy in both individual and group, units of substance use counseling, units of support groups, units of wellness instruction, and units of bus and van trips to medical appointments. Next slide, please. HAB indicators. Next slide. Okay. HAB indicators include the performance and outcome data are collected and tracked on the following indicators: the percent of patients with a denominator of HIV viral load less than 200, percent of patients regardless of age with a diagnosis prescribed. Basically, these are the HAB indicators. We kept to them. We will be changing them over time. The percent of patients regardless of age who do not keep a medical appointment. The thing is, we do take the clients to medical appointments, and all the clients are virally suppressed. The percent of patients who were prescribed prophylaxis for PCP, right now I believe we had 2. So a sample of, next slide please. A sample of success is that 100% of the 16 clients who came to us who were not virally suppressed are now all have an undetectable viral load. They had that within 3 months of residency. 100% have attended all medical appointments in the past 6 months, and their comorbidities are being addressed: medical, mental, and substance use. After an initial stabilization period called the orientation phase, usually 3 months, and dependent on reassessment, the client will begin to use their newly acquired independent living skills. Residents work, attend college, or engage in vocational school. They reconnect with family, create substantial savings accounts, and volunteer in the community. The home environment is improving residents' self-worth and self-efficacy. They are confronting their internalized stigma, learning how to redefine their relationships to the GBTQ community without drugs or alcohol in a safe and comforting space. One resident, who was the first resident, just moved into an apartment. We have 2 residents in college, we have 2 in cosmetology school, and we have 3 clients who went to work and have now been promoted to managers in their specific fields. Next slide, please. Barriers to implementation. Finding licensed staff that are interested in this type of counseling was difficult, particularly certified in DBT. However, looking to the future, we have included a contract to train and certify up to 6 subrecipient staff throughout the state in DBT. Substance use of all types remains a serious barrier to care, with clients relapsing repeatedly. Maintaining a certified substance abuse counselor in the house and having close relationships with inpatient and outpatient treatment programs was a must. Youth perceived marijuana as a norm and not an illicit substance, which is always an interesting conversation when they come back from PASS. Again, these are not dischargeable offenses. Using drug treatment as an example, we really could not predict sufficiently what mental conditions existed prior to drug use. Serious mental health conditions have come to light after residents have stabilized in the house. Assessment and reassessment, as trust increases, builds the relationship to better address surfacing conditions. Some homeless youth are resistant to structured living and opt out of housing. Several that came to the program gave it a chance and have succeeded, with several others left to return after a short time. Building hope in the possibility that their life can change is essential to retention. Several of the clients who left, based on their assessment of needing more intensive substance abuse treatment, received that treatment immediately, on demand. Next slide, please. Lessons learned. We had no real model or an approach that emphasizes the need to be flexible and willingness to adapt to the real situations. So work flexibility into programs, make room for residents and staff to give feedback and have their feedback work into the programs, the way how the program is run. For example, residents want a workshop on healthy relationships. They wanted a movie night. They wanted HIV support groups. The staff wanted a chore chart. So all these things were integrated. This is an emotional and difficult program to run, so it's beneficial to have a flexible mindset. Get to know your collaborative partners and co-location of services such as HIV prevention and GED education. Make trauma-informed care a priority. Don't neglect staff development and wellness. Don't be afraid of staff turnover. It's better than having the wrong person impacting the clients. Their professional development is as crucial to the program as the house itself. Next slide, please. This housing program led us to 3 other initiatives that built on the home. Trauma-informed learning community. According to the Substance Abuse and Mental Health SAMHSA, a trauma-informed service organization responds by fully integrating knowledge of trauma in policy, procedure, and practices, and seeks to actively resist re-traumatization of patients. Recognizing the negative impact of past trauma on HIV care, engagement, high-risk behavior, and treatment failure, the department aims to establish a trauma-informed community of learning in New Jersey to help mitigate this impact. The Department of Health engaged the services of CAI, formerly Ciccatelli, to conduct a 2-year project to integrate trauma-informed approach to HIV care and support. CAI uses the IHI Breakthrough Collaborative Model to help organizations translate evidence into practice and ultimately to improve performance and quality of care. Working in collaboration with the Department of Health and the leadership of subrecipients, CAI will use the health systems approach to align resources, build organizational and staff capacity, and ensure coordination across HIV care and support services statewide. We'll utilize blended learning strategies to explore needs and gaps in our system. We'll build skills to support implementation and ensure the integration of a trauma-informed approach is sustained over the project period. Next slide, please. CAI will conduct a rapid on-site assessment of 3 to 4 HIV providers and CBO teams identified in partnership with trauma experts' knowledge about existing providers conducting trauma-informed care. The one-day seminar training will also serve as an opportunity to strategize with the Department of Health to establish roles and responsibility for key stakeholders, identify gaps in information that must be gathered from agencies. CAI will conduct an organizational needs and readiness assessment with all implementing agencies, partner CBOs, and key stakeholders. After the completion of the exploration phase, CAI will work with the department to engage a full range of stakeholders for implementing planning purposes. During the implementation phase, CAI proposes to facilitate a learning collaborative to support agencies during the implementation, provide an opportunity for collaboration, and for peer learning. Next slide, please. The second component in our ball of twine that's ever growing is our mental behavioral health collaborative. New Jersey HIV care continuum data showed there are still opportunities for increased engagement and retention in care. During the recent HIV cross-part continuum collaborative, care providers examined non-suppressed patient cohorts to identify primary drivers or root causes for non-suppression. In the statewide aggregated data, mental health was identified as a potential driver of the largest subset of non-suppressed cohort. These data show that PLWH experience substance use disorders, which can worsen the progression of HIV in disproportionately high rates. Ensuring systems of care have both the capacity and competency to provide care to PLWH is imperative to achieving outcomes. As Dr. Laura Cheever wrote in January of 2015, while screening tools go far for identifying mental health conditions and suicidality, social stigmas associated with mental health treatment persists. Addressing such conditions, however, is critical to overall well-being and quality of life for the person living with HIV. Ensuring a comprehensive system of behavioral health can support early identification of needed behavioral health services, early assessment, timely referral and linkage, and ongoing support to sustain engagement in care has been shown to decrease costs and improve outcomes. The Northeast Caribbean AIDS Education and Training Center has been funded to institute a 4-year statewide project using the Institute for Healthcare Improvement Collaborative Model for achieving breakthrough improvement, which is evidence-based method to actualize system improvements through peer-based learning and collaborative problem solving. Next slide. The methodology, through a series of in-person and virtual learning sessions and action periods, providers will come together over a period of 24 months to examine their systems and determine methods to improve outcomes related to behavioral health services. The primary aim is to close the gap between potential and actual performance by testing and implementing changes across an organization. The elements include, and basically this is just a topic selection, facility recruitment, enrollment, participating, learning sessions, plan, do, study, act, evaluations, and publications. Next slide, please. The last rung on our ladder right now is a housing cooperative. The aim was to establish a statewide housing cooperative utilizing the New Jersey hotline as the main hub to coordinate housing referrals and inventory across the state. We contracted with the lead agency, the AIDS Resource Foundation for Children, who will be our pipeline, who will create a pipeline. A pipeline is a chain of facilities that represent the much-needed services of the PLWH facing homelessness. The goal is to train at least one ambassador at each designated pipeline. The agency will network, access, and coordinate each of the COC bodies. The collaborative's presence will eventually extend to county-level mental health boards and local advisory boards on drug and alcohol. The network will assess the existing state-funded entities to work with the PLWH, medical case managers, medical providers, and counseling and testing sites. We will conduct asset mapping within our partner services to create opportunities for all to use their unique qualifications in the most prolific manner. Using asset-based thinking, the H Resource Foundation will conduct a needs assessment of each of our 21 counties. The needs assessment will determine the presented demand of homeless services, the PLWH in each county, and document the existing services. I should also say that the emergency services will be Any emergency call will go through the hotline and patch through to a 24-hour on-call housing expert who will house an emergency within 2 hours of the hotline call. Lastly, in September, New Jersey received a Part B supplemental award to develop a structured, clinically based home for HIV-positive women who were victims of early childhood sexual assault and or intimate partner violence. The RFA will be released in October 2016. Next slide, please. In addition, the lead agency for a housing cooperative will facilitate focus groups with service providers and consumers in different counties to get relevant and pertinent feedback. Doing so will allow us to document and share best practice in an effort to create uniformity in care throughout the state. We will foster a professional learning community with non-medical and medical case managers and community health workers throughout the state in order to create a community of learning, training, and growth. We will ensure that every service provider is aware of the procedure and usage of the hotline for emergency placement within 2 hours through the on-call staff. We will increase the efficient statewide use of HEMIS to provide real-time information on available beds throughout the state by assessing the challenges to data entry and data accuracy, making recommendations for training needs, and providing technical assistance specific to the issues of a housing cooperative. And that's what New Jersey's doing. And I would like to thank everyone for their attention. And this is my information if you have any questions.
Great. Thanks so much, Loretta. You've been doing a lot in New Jersey, so a lot of information there. And I want to say to folks who are, watching us in their offices or teleworking from home, it's okay if you want to get up and stretch. It's been a long hour and a half. I can't do it because you can see me on the webcam, but no one's watching you at home. So go ahead, get up, stretch, and have a cup of coffee or something. So we're getting towards the point now where we are going to go to the next slide. Begin our community input session. So we're going to be taking people's comments and questions, and we're going to be having this facilitated by Harold Phillips, who has so much experience that you can't see this, and I'm just teasing you, Harold. His bio is twice as long as anybody else's on the program today, and that's because he's done so many things. So Harold serves as the director of the Office of Training and Capacity Development at the U.S. Department of Health and Human Services, Health Resources Services Administration, HRSA, HIV/AIDS Bureau. And his office administers the Ryan White Program's AIDS Education Training Centers, SPINS project, as well as the President's Emergency Plan for AIDS Relief for PEPFAR activities. He serves as a senior sponsor for the HAB HIV Homelessness Work Group and has done a lot over his past 20 years in HIV and AIDS, working in Ryan White programs and serving in a variety of capacities. A lot of his work is focused on monitoring and evaluation and needs assessment. That's really kind of key to the work that we're here talking about today. But also his experience includes work on disparities in access to health care for key and priority populations in the U.S. and in PEPFAR countries. Mr. Phillips served on the CDC HRSA AIDS Advisory Committee from 2003 to 2010. He has a master's degree in urban and regional planning from the University of North Carolina at Chapel Hill and an undergraduate degree from Kalamazoo College in Michigan. So I think, Harold, we may have the same situation going on your end with another phone having a speaker open because we can hear a little bit of feedback. So we can get everybody to turn off their volume where you are. I think it got better all of a sudden. So Harold, you're going to lead the input session from our participants, right?
I am, Rich.
Okay.
Thanks for all that. You were only supposed to read the first paragraph. Good afternoon, everybody. So as we go into the community feedback portion of the webinar and call today, we'd like you all, we definitely want to hear from you all. We encourage you to be concise, limit your comments to 1 to 2 minutes, and we're also hoping that the federal staff listening in will be in listening mode rather than responding or reacting. And we'd also love for the speakers to identify themselves and tell us where you're located. And with that, I'll turn it over to Nathan, who's going to give us some instructions about how all of this will operate. Nathan?
Yeah, sure thing. So everybody who's on the webinar, you can do basically 2 ways of entering questions. One is you can enter it into the questions tab that's on the webinar control panel, and then we can all read your questions that way. or if you're on the webinar, you can raise your hand. That's an option on the control panel as well. And then basically we'll go through and Harold will identify who you are, and then we can unmute your line and you can ask a question. But if you want to use your phone, if you want to do that, you have to make sure you enter in that audio pin when you first join the webcam or the webinar. And it's basically, you'll see it under the audio section. If you don't enter that in, we won't be able to hear you. So you can raise your hand, we can unmute your line, but we won't be able to hear you. So again, that's the two options. You can enter in the chat, or you can ask a question over the line.
And this is Rich. I'm going to jump in real quickly and just kind of remind folks that, really, we're hoping that you're not going to be asking questions so much today, but rather that you're going to be giving us input and providing feedback as to what you think needs to be done and what you think needs to be changed as part of the federal response to housing among people living with HIV. So as you submit things on the question tab, and we can't change the name of the tab, that's the way the software comes, we're probably going to prioritize focusing on those that are really more recommendations or raising issues that can inform the work of this subcommittee. So Harold, take it away.
Thanks, Rich. So with that in mind, one of the things that the work group is really interested in hearing, as Rich said, are innovative approaches being used at the local level to improve housing and healthcare outcomes for people living with HIV. We're also interested in hearing your experience in working to overcome some of the barriers, as well as recommendations that you may have for the work group. Okay. So with that, do we have anyone who wants to start us off?
I hope we didn't put everybody to sleep with all of those presentations. It was a lot of information, but there was a lot of good stuff in there too. So.
And Harold, this is Nate again. I'm looking through, there's about 600 people on the webinar, so I'm looking through for a hand raised.
Okay, that's terrific.
Somebody asked in the questions tab if you could repeat the question you'd like input on.
If I could repeat the question.
Yeah.
Certainly.
So you're looking for innovative models and programs, right, Harold?
I am definitely looking for innovative models, programs. Even talk to us about some of the barriers that you've worked at the local level to overcome. And because I think that'll give us on the federal level some insight, because oftentimes we create programs or policies and have an idea of how they're going to be implemented. But when they actually get on the local level, sometimes they conflict with either state or local programs and policies and create barriers that sometimes we find that our community partners are being innovative in their approaches, but sometimes we don't hear about sort of those barriers, which, when we know better, we can do better.
And I thought Heather gave some great examples of programs funded by the Secretary's Minority AIDS Initiative that they've done at HRSA that have really tried to work with communities to develop those models. And I know other people have them as well.
Yeah.
Yeah, and Harold, this is Nate again. I just want to remind folks, if you wanted to ask a question over the telephone, just make sure you raise your hand on the webinar platform system on that control panel that's on your screen. There should be a little hand that looks like it's giving a high five. You click on that, and that's how you get queued up to ask your question.
Yeah.
And it does look like there's some people who are typing in questions. I guess they're a little shy to speak over the phone. But that's okay.
That is all right. So while we wait for that, Rich, one of the questions that was in the box that you may want to take on, I'm trying to find it here, was about the National HIV/AIDS strategy itself. And I'm going to see if I can find that in the box, because I thought it was a perfect question for you to kind of answer, and I think you did some of this in your opening, in talking about the strategy and the work that we're doing on both the indicators and the overall national goals. So it is. It's great to hear that there's so much great work being done to meet the NHOS indicators. Can you speak to the broad concerns about the future of NHOS, and should we be reassured that the work of the NHOS is continuing with federal investment?
Thanks, Harold. Yeah, I guess that is a perfect question for me, huh?
Yeah.
The work of the National HIV/AIDS Strategy Federal Interagency Working Group has been ongoing. The transition has, taken some time between administrations, but during that time, the federal agencies and offices that have made commitments and are working towards achieving the goals of NHOS have kept on working. So we've had these working groups that have addressed the areas where we have not met our goals. We've been reporting on progress. For example, if you all don't keep up with us on hiv.gov, you can hopefully go there today and take a look at some of the information we've been sharing that's come out of the CDC monitoring report, where they have published updated data on progress on the NHOS indicators. Unfortunately, we did not see the trends turn around for this indicator, and we're still not meeting our goals for housing status. So the discussions that we're having today are important not only for looking back at where we were last year, but are relevant to this year as well. So we're committed to continuing to do the work under NHOS, and quite frankly, I think the thing that we need to be focusing on now is starting to think about where we go with the next national strategy. The current strategy runs to 2020, and the way things typically work is that we would have to get started probably sometime next year in developing the new strategy and in articulating the new goals and directions for that. And I think the timing for that's great. Healthy People is focusing on their 2030 goals. At the most recent meeting of the President's Advisory Council on AIDS, they talked about where we might go with the next NHOS. And so we're really excited about beginning the work to define where we go from here, because as everybody knows, so much has changed just in the last couple years that we really need to be thinking about how to leverage the new technologies and the new opportunities that we now have at hand. So the work's still going on, folks.
Thanks, Rich. So one comment from Don Hunt, who is in Illinois, and my chat box jumped a little bit, and serves as a retention specialist, a specialist for the regional Ryan White program. And in that role, a lot of the homelessness that he sees is due to substance abuse and HUD policies regarding applications from ex-offenders, and really wondered about any discussion about increased substance use treatment, bed space, and looking at HUD policies concerning ex-offenders. So, I think both at the HHS level and in other programs, there's been a great emphasis on trying to address substance use disorders. And I think we'll continue that, especially as we're seeing in a lot of our clients an issue that tends to cause individuals to fall out of care. We're doing, I think, both a lot of provider education, as well as trying to educate the community and educate our patients about the availability of sort of these braided funding streams of programs that can help address both homelessness, HIV, and substance use. Another comment from in North Carolina, the Ryan White Part B and Hopper programs have historically been integrated. We have since further integrated with the CDC HIV prevention program. The way we did this was to develop a joint prevention, care, and HOPWA request for application and funded regional networks of care that included funded and non-funded providers to work with people living with HIV to get linked to care, support housing, and prevention services. Our goal is to ensure more focused testing of high-risk individuals, link them to care, housing, and supportive services. Through the regional networks concept, we hope that people living with HIV have multiple points of entry into care and housing. And that was from North Carolina. And I'm trying to see if there was a name of person that was there. Detra Purcell. So again, I think great example of how both at sort of the integrated planning model and incorporating housing into that is hopefully leading to both some braided funded programs that can address needs in a more comprehensive approach. So that's exciting to hear.
Absolutely. Great work.
Yeah. From Lacey Nager, I would agree that substance abuse and mental health issues are what keep some of our folks homeless. Supportive housing is greatly needed. I know some of the projects you mentioned seem to be doing this very well. Yeah. I don't know if there's anything our HUD colleagues want to add on with regard to supportive housing, but yes. Let's see.
Sure. I mean, I would say HUD TOPL program and you know, the Continuum of Care program and other homeless programs that were mentioned earlier, you know, fund permanent supportive housing. And we also wanted to comment, you know, on the issue of, you know, ex-offenders and barriers for ex-offenders that was brought up a few minutes ago. There is a lot of misunderstanding on the local level about, you know, what the actual HUD, you know, regulations and policies are regarding serving ex-offenders. There are a few restrictions that apply to HUD's public housing programs, and those same restrictions do not apply to HOPWA and HUD's homeless programs. So there's definitely some information around, you know, who can be served by HUD's programs and, you know, how criminal records impact that. And maybe, you know, as a follow-up to this call, more information can be provided clarifying that.
Right. Thanks. So I'm going to take these next two. One is from the Houston field office, calling for more housing models exclusively for the transgender community. And this is from Darlene Swearington in the HUD Houston field office. But also there is, along similar lines, a sort of question or recommendation from Dr. Hiram Rivera Mercado, who's in Chicago at the VA and is currently the LGBT psychology fellow, and is still trying to figure out if whether or not there are better data on transgender individuals and also initiatives that may have been implemented. In his work, he has encountered a lot of transgender individuals who are homeless and HIV positive, and it's hard to find ways that address their multiple complexities. He's seen a lot of focus on gay and bisexual men, but doesn't know if there is something being done for this specific population. And I would say there are a number of programs that are out there. Peter, you from Chicago, you may also know some of those resources that are out there. But you are correct in that some of the very special needs of the transgender population sometimes require us to think outside the box and figure out programs and service delivery models that can really meet those needs, and those needs being different from gay and bisexual men. Peter, anything you want to add to that one?
Sure. So there are some specific projects here in Chicago that serve people who identify as transgender, and there is a Trans Life Center operated by one of our local community-based organizations that has an array of resources, including employment opportunities that are sensitive to people who are transgender. AFC also has a project that braids funding with a local continuum of care and serves people who are specifically transgender. It is that housing first model where people have their own leases and live in private market apartments, and it has intensive housing case management that's attached to it. So I think that the doctor is correct that there are definitely specific needs, and I would be happy to speak with him further about connecting to some of those resources that exist here in Chicago.
Great, great. And one of my colleagues also reminded me of Chicago House in Chicago, which also provides housing for the transgender population. So there's just one more that I'm going to share before I turn it back over to Rich, and this one comes to us from Travis Hutzel, who's left the call, but is a care coordination nurse at our House of Portland in Oregon. And they have a program called Neighborhood Housing and Care Program, where they send RNs and social workers and occupational therapists into the homes of people living with HIV in order to support them in staying housed. For those who want more information about that program, I know I'm definitely going to check this website out. It's www.ourhouseofportland, that's all one word, OURHOUSE of Portland.org for more information. So I think some great examples have been shared, both some recommendations and a few questions I think that we did get answered as well, Rich. So I'm going to turn it over to you to, I think, close us out.
I think that's exactly what we're going to do, Harold. So thanks so much to you for great facilitation and for everyone for their participation. Now, I know we had a number of people who had their hands up in the chat function, and I wanted to let you know that you and everyone else is welcome. And in fact, I want to encourage you to send us your thoughts and comments, copies of articles or materials that you have from your programs. To send them to us at contact@aids.gov. So contact@aids.gov. And we can send an email out to everybody after the webinar to give you that email address again as well. One of the other things we're also going to email you about to remind you, or perhaps even let you know for the first time, is that we're having another webinar on Thursday that is related to the National Viral Hepatitis Action Plan. As some of you may know, there are 11 priority populations identified in the action plan, and we had a webinar on September 14th that addressed homeless population as well as a number of other populations that are at higher risk for viral hepatitis infection or consequences of the disease. And so this week, we're going to be focusing on racial ethnic minorities, pregnant women, and baby boomers who are at increased risk for hepatitis C infection. So I think a number of you may be interested in that webinar as well. I also want to point out that the webinar that included homeless populations in it was recorded, and we haven't yet got it up online, but probably in about another week or so, you'll be able to find that online at www.hhs.gov/hepatitis. So I really want to thank you all for your participation today, and most importantly, for the work that you do to support housing and to help make the lives of people living with HIV in the U.S. better and healthier. So thank you so much, and look forward to hearing from you all by the email and having you all again on a future webinar. So thanks so much for being here today. Bye-bye.